Good morning, everyone, and welcome to the Public Safety Solutions for Substance Use Disorder ECHO. My name is Julio Soroblanco, and I will be the facilitator for today's session. This ECHO is brought to you by the Center for Substance Use Training and Telementoring, also known as CSTAT, by Be Well, Texas, in collaboration with the UT Health San Antonio ECHO program. A few housekeeping items before we begin. We have live closed captioning available for today's session. If you would like to view closed captioning for this session, please navigate to the bottom of your Zoom window and select the Show Captions option. If you're having trouble accessing captions or having connection issues, please chat Echo IT Taylor for any assistance. To help us with attendance, please enter your full name, affiliation, and email into the chat. Please remember to stay muted unless you are speaking. We encourage joining by video and using the chat and/or raise your hand feature to pose questions or share perspectives throughout the session. And as a reminder, these sessions are being recorded and will be shared on our website. To ensure privacy, no personal health information is allowed at any point during the session. This includes client or patient names, addresses, birth dates, or any other identifiable information. At the end of the session, the ECHO team will send out a post-session survey link. We kindly ask you to complete it as it provides feedback on how to refine these sessions to better address your priorities. We're approved for CEs for paramedics and any public safety professionals with a behavioral health degree, such as social work or counseling credential. Finally, ECHO is an all teach, all learn environment, and we do encourage everyone to participate in the conversation and raise any questions. With that, we'll move on to some team introductions. First up, we have Dr. David Miramontes.
Howdy, this is Dr. Dave Miramontes. I'm the Chief Medical Officer for the San Antonio Fire Department, and I work for UT Health.
Thank you, Dr. Miramontes. We also have Dr. Brandon Del Pozo.
Hey, good afternoon here and good morning in other time zones. I'm coming to you from New York. I'm an assistant professor of medicine and public health at Brown University. Was also a chief of police in Burlington, Vermont for 4 years, and I spent 19 years in the New York City Police Department. Welcome back to returning folks and welcome to new folks.
Thank you so much. We also have with us Cynthia Mendiola.
Good morning. My name is Cynthia Mendiola. I am here as a retired federal probation officer. I work in immigration safety, and I'm also a trainer and coach in core correctional interventions. Thank you for being here.
Thank you all so much for being here. And our case and didactic presenter for today is Dr. Brian Dillon.
Hi, everybody. Thanks for having me. My name is Brian Dillon. I'm a physician, board certified and trained in emergency medicine, as well as addiction medicine, primarily practicing addiction at this point. And I've been involved with street medicine San Antonio for the past 6 years or so, and I'm currently serving as medical director of the organization.
Thank you so much for being here today, Dr. Dillon. Let's get started with our didactic presentation. Dr. Dillon, once you share your slides, you may take it away.
All right. Well, like I said, thanks again for having me. I think I got introduction out of the way. I'll be talking about caring for the vulnerable in Texas and the role of street medicine, as well as its connection to public safety. Next slide, please. I don't have any disclosures, and there's one slide where there's some images of some wounds. So I'll give you a heads up when that slide's coming if you prefer to not look at that one. But just a warning on that. We'll go through these learning objectives, kind of define the purpose and mission of street medicine, the why, or so to speak, of why we do it. Go on to explain what street medicine is, what exactly do we do, how do we do it, and who are we helping, and then also explain the process of referring unhoused patients to street medicine, both locally and with the other street medicine programs that are in Texas. Next slide, please. So starting out with why. Why do we do street medicine, and what are some of the factors that we motivate us to do what we do? I think for all of us here at Street Medicine San Antonio, I mean, we're still up to this point 100% volunteer organization or a nonprofit. And I think everyone that's involved obviously is doing this in their spare time. And I think because they have a personal calling to help the marginalized, help those that are specifically unsheltered, as I'm sure many on this session feel the same. And so that's what brings us together. But underlying that are some real data that show just how disadvantaged and marginalized this population is. For instance, nationwide, the average lifespan of a person experiencing homelessness is about 50 years old. That can be a little bit higher depending on where you're looking, but overall, nationally, that's about the average. This next bullet point's a little bit of a typo. It's 2/3 of homeless individuals have 2 out of 3 of the trimorbidity kind of trifecta of disease, that being substance use disorder, severe persistent mental illness, and multiple chronic unmanaged medical illnesses. The number percentage-wise, depending on where you look across the nations, anywhere from 15 up to 30% that have actually all 3 of those trimorbid conditions. For every age group, homeless individuals are much more likely to die of various causes than the general population. And another reason and benefit of street medicine is that we can reduce the cost burden to the health system of the individuals that have to frequently get into the health system, usually when things are unmanaged and out of control, which means an ER visit. Um, and me being in addiction medicine practice at this point, kind of have a special interest in substance use disorders. And I know that a lot of you encounter folks with substance use disorders probably on a regular basis. And so just wanted to touch on that and say that, it's an easily misunderstood disease. And I think it goes a long way to try to appreciate, where that person's at, know that, by definition, addiction means they've lost control of their, actions. And so I think it's good to come from a point of compassion and empathy for them. Next slide. And so what exactly is street medicine? It's pretty much what it sounds like. So we literally bring medicine to the streets. A lot of what we do is help get patients plugged into resources. That's probably the biggest part of what we do. Obviously, we do some medicine and do what we can, with the limitations of being out on the street. And so, we focus on engaging them where they're at. We go to them, obviously, we go to their encampments and meet them, even sometimes right where they're sleeping, and offer them, gauge their interests on first of all, what they need and what they want from us, even though we may feel differently on what they need or what they want, and start there. And that may mean, we don't get a full history and physical the first time we see them. We may give them some over-the-counter stuff like Tylenol or something just to establish some rapport. And a lot of times it takes multiple encounters to kind of build some rapport and for them to be trusting and willing to let us treat them more comprehensively, get them plugged in with all the outreach organizations to help them with safety, with housing, with psychiatric and substance use treatment. And we also do harm reduction as far as, distributing Narcan, clean use supplies, needle exchange, that kind of thing. Next slide, please. We don't consider street medicine adequate, full, comprehensive primary care. It's just not feasible to do that on the street. However, if the alternative is nothing, it's something, and it's usually a good bridge and an intermediary to comprehensive primary care. And so I'll get into some of the details on exactly what we treat and what we're able to offer. Our organization here in San Antonio is under the nonprofit Imago Dei, and our organization specifically is called Street Medicine San Antonio, and we've been established since January 2019. Next slide, please. And so where do we go and when? Right now, being all volunteer, our schedule's kind of at the mercy of what everyone has available, so it's highly variable. But generally speaking, right now we're usually going out at least 2 to 3 days a week for about 4 hour sessions, and that includes MDs, PAs, nurse practitioners, EMTs, RNs. All of those can serve as a team lead or go out, together. And we usually bring students, residents with us for learning opportunities as well. We go to streets, bridges, under overpasses, ditches, encampments, wherever they're at, and try to meet them in their own space. Next slide, please. How do we do it? We literally carry everything in a backpack or a bag, kind of like you see here. We bring all necessary equipment to get vital signs, deal with wound care. We carry a lot of over-the-counter medications as well as prescription meds, including antibiotics, steroids, inhalers. And yeah, I think that's about it on that one. We usually will drive to the nearest, spot that we can get to by vehicle, and then pretty much every time we're usually walking or hiking into the areas where we know the patients are, or where someone else has told them they are, and take all our stuff with us. Next slide, please. This is that slide I was talking about, so please, if you are perturbed by wounds, look away right now. But these are just some images of things that we've dealt with and we commonly deal with. For instance, this cast that was long overdue to be removed, and the patient just did not want to go back to the ER to have that done. So we managed to get it off with some trauma shears in the street. That's me doing an IND of an abscess, and then another individual with unmanaged wound and what we believe to be untreated skin cancer. Next slide, please. In 2021, in the Bexar County Medical Society periodical, we published a review of just some of our internal data on like what we've been seeing, what conditions we were treating, what types of individuals we saw, what medications we handed out. And this was 2021, so this was just about 3 years after we had started doing street medicine, and since then it's grown quite a bit. But this is just to give you a glimpse of the things that we see, primarily skin-based stuff, skin infections, musculoskeletal complaints from untreated, injuries, chronic pain, upper respiratory stuff, like viral URIs, pneumonia, COPD that's unmanaged. That's primarily what we're treating. And then, less commonly, GI issues, neurological issues, etc. Next slide, please. And here are the medications that we most commonly will hand out. Most commonly is the over-the-counter stuff, Tylenol, ibuprofen. We definitely don't do any stronger pain medicines than that. Antibiotic ointment, and then antibiotics and steroids like prednisone. I think currently, as of now, are probably the most common prescribed meds that we hand out. We used to get those through some other nonprofit pharmacies who would provide those to us for free. Now we're able to purchase some of those with donated funds. And as far as patients, this was for a 2 year period. Kind of like I said, right after we got started, about a year after we got started, we saw 220 patients of those 2 years. I would estimate that that's probably tripled by now. I'm fairly certain we see, at least double, triple that every month. And that's just because we've kind of grown more established. All the outreach organizations know who we are now, and so commonly refer patients to us. Back in the early days, we would kind of patrol around looking for individuals who might need help. And now almost every time we go out, we have a full schedule where we're trying to follow up on as many people as we can, whether we've seen them before or haven't. The vast majority of our patients, we actually only see one time. And most often that's because we just lose contact with them. They don't have cell phones. It's hard for them to, say, I'm going to meet you on this day, 3 days into the future, when they don't even have a phone. And then when they don't show up, there's no way for us to get a hold of them. Sometimes though they don't really need a follow-up, but we'll still try to touch base with them again to try to get them plugged in and develop some more rapport. Next slide, please. And so, dealing with the most common problems, one being substance use disorder, mental illness is also a really high, very common comorbidity we see in these patients. And so, as a means of addressing that, throughout the years, we've been trying to develop a more robust way to deal with mental health issues. We do have a LCDC who works with us closely, and currently working to get a psychiatrist to partner with to do what we call Street Smart San Antonio. And their goals are to eventually be able to administer long-acting injectable antipsychotic medicines, as well as do weekly rounding, kind of in parallel but separate from street medicine, so that way we can, divide and conquer, so to speak. Next slide, please. As far as referrals, so for our organization specifically, primarily referrals come through a dedicated email that our coordinator will manage and then schedule out, follow-up appointments with whatever team lead is going out next. And then we usually directly will communicate with whatever outreach organization or social worker contacted us while we're out on the street to try to help find the patient. And that's usually pretty helpful because they already have some rapport with the patient. They tell them we're coming. They know where they are. It makes it a lot easier to find them and to help them. We do refer as well back to the social organizations and outreach organizations, especially if they haven't touched base with them, try to help patients, get an ID, get into substance use treatment if that's what they want to do, and ultimately get plugged into primary care in some way or fashion. Rarely do we have to send patients to the ER. I think over the past 6 years, I've called EMS twice for some pretty acute stuff. But for the most part, we're able to get them into primary care of some sort, whether it be Central Med or Travis Park Church Clinic downtown. And then on the next slide, probably the easiest way, you can go to the next slide, the easiest way for you to get in contact with us is on our website at the contact page. There'll be our email address there where you can send referrals. Texas has quite a few street medicine programs now. I'm pretty familiar with JPS in Fort Worth. We've gone out with them and visited with them to pick their brains, but they probably have the most robust program in the state. They're integrated in with the JPS health system. They are integrated with the residency. They take residents out regularly. And they have a mobile medical van. They go out every single day. They have dedicated funded faculty for that. And so they're doing pretty amazing work there. Street Medicine Austin, I think, is fairly new. Their website is listed there as well. And then Houston as well, I think just in the last few years has started their own. And then there is one now being started in Dallas, I believe, connected with Baylor Scott and White. That is also in the works. And so becoming more widespread and definitely, hopefully, reducing the burden on the healthcare system as well. And then just the last slide there. Just some references, but that's about it.
Great. Thank you so much, Dr. Dillon, for that great presentation. At this time, I wanted to open up to the Learning Network for any questions that we have for Dr. Dillon concerning his presentation, the work that he does. Any questions at all, feel free to unmute yourself or post them in the chat. Andrew, I see that you posted a question in the chat. Would you be able to unmute yourself to ask your question?
I see that you're asking about community health workers.
Yes.
Yeah.
Hello.
So in fact, we don't have any yet, but it's definitely something we're planning to integrate soon. It's a little bit of a long story, but we're just in the early stages of receiving some grant funding. And as part of that, we plan to hopefully fund a community health worker to come out with us. Especially
Okay,
somebody, if they have lived experience, would be ideal. But yeah.
thank you.
Great. Andrea, I see you have your hand raised. Feel free to unmute.
Yes, I have a question. How often do you see them, specifically people who are part of the unhoused population, coming back and following up on recovery treatments, the ones who have substance use disorders?
It's highly variable, as you can imagine. Our biggest challenge is finding the patients. Even if we've found them once, they often will get moved around on where they're able to sleep and establish kind of their living situation. Um, and so we'll see patients sometimes once a week if needed, especially if they're kind of in a more established spot and we know we can find them and they're going to be there. As far as for those who want to get into substance use treatment, um, as I'm sure Dr. Miramontes knows, like the EMS, MIH, Mobile Integrated Health, we've seen a few of those patients who have been started on Suboxone or tried to get them in with MIH to get them set up, and then we'll also refer them to CHCS downtown. And there's been a handful that we've been able to get in through that way, but it's been really challenging because unless they can get set up with MIH, they're having to go, downtown to CHCS. They have to somehow get a bus or ride or something to get down there every day, and it's very challenging. But there has been definitely, I can think of at least a few very successful cases where they've gotten into treatment, and that's been the impetus to get them housed and ultimately get them, off the street. And I guess on that note, like I'm hoping with some of this grant funding and we're able to get our program a little more robust and able to provide more care, that ultimately maybe someday we can actually be doing what MIH is doing and do Suboxone inductions and follow-ups on the street. I think that'd be really nice.
About to say the homeless population is real, or those that are unhoused are really our biggest challenge. A lot of our clients, we actually get them connected, and our meeting point is actually Corazon Ministries. I have 2 patients there right now that we're going to dose, and that is our meet spot, right? Because come here for lunch, we'll see you there, and then Cody is our person with lived experience that gets them integrated, but without a phone, without an ID. You can't do OBOT with them because if you give them a bunch of their medicines or fill a prescription, it gets stolen, right? They have no place to secure their meds. So it's really a challenging population. Sometimes we do rehab first, housing first, as an option. But a lot of these clients aren't ready for that. And so it's just the recurrent touches, the harm reduction until they're ready to, come off the street a little bit for a period of time to get back into care. But it's usually housing first is usually the goal. And this population's tough because they don't want housing. They don't want rules. They don't want to live with other people. That's not their modus operandi. And of course, you touched on they're the triple threat, right? So they're unhoused. They usually have mental health issues, and the substance abuse is them self-medicating their mental health issue. So if you don't address all 3 at once, it gets really difficult, unfortunately. But yeah,
Yeah,
it's
well
a rough
put. Well
population.
put.
Rough population.
Very challenging. And I've even seen, at Township Village, the Housing First community here, seen some of our patients that we know well, and they were uncomfortable being inside. It's a huge adjustment. So, but yeah, Housing First definitely makes everything else easier by far.
Yeah, and
Well,
unfortunately, all
I'm
the
sorry.
things that we're doing and the process that we're doing currently is currently been upended by the White House's current executive order. So a lot of the great work that you and other people are doing with harm reduction, housing first, that kind of stuff, that whole mantra and philosophy that which we know works from the literature has been upended. So it's going to be a very challenging 3.5 more years, let's just say.
I just wanted to add that there's got to be a starting point in this street this project on street medicine is it's awesome, and your starting point, you know, it's always a challenge in those programs, and eventually hopefully there's like one-stop centers that you can pop up, you know, with the starting point of the street medicine as well for these people.
Yeah, and locally there are through some other organizations some regular sites where individuals can go and get help, um, specifically some for harm reduction and wound care. And so we try to have a presence there alongside them as much as we can. We work really closely with Corazon and other outreach organizations. And part of this grant that we're entering into is to hopefully integrate more of us kind of on the same page, and so we can more strategically, reach as many people as we can.
Great. I think we have some really, really good questions. Um, any other questions for Dr. Dillon or any other comments, thoughts, concerns? All right. No worries at all. I did have one question for you, Dr. Dillon. I know you'd mentioned it a little bit, but in building sustainability, and you'd mentioned like funding sources, what are the goals for your organization to further create a sustainable system that they can carry on?
Yeah, so it's a good question. That was a large part of our decision to enter into this grant partnership, was to we decided, we needed to, there's a growing need far outpacing what we can do. And we felt the call to try to increase our services, and part of that is getting money, right? Everything requires money, and ultimately that's going to allow us to dedicate more time to this. And specifically, I'll be, doing this regularly, multiple times a week. Whereas before, I could only dedicate a couple of days a month. But also, it's going to help us get the supplies we need, provide medications more reliably, and hopefully, we're hoping like have some regular, employed positions so that we can just continue this and grow it, and just all of us be able to dedicate more time to it. And I think eventually, if we're being realistic, we are our own nonprofit organization, but I think um, in order to really reach more individuals, we're going to have to integrate with one of the health systems, probably, university or UT Health, um, especially because we already work really closely with them and host their residents, and provide education opportunities as well. And so I think that's the direction we're headed. And hopefully, this first grant is just one of many that's going to help us continue to grow.
Great, definitely. So we wish you all the best in your organization and in your growth. And thank you so much for your presentation. Thank you so much, everyone, for all your questions and all of your feedback. With that, I would like to go ahead and move to our announcements. Taylor, if you could pull those up, please. All right, to claim your CEU credits, you must complete the post-session survey in the chat or by email sent after this session. Complete the post-session survey and select yes on the question, are you applying for CEU credit for today's ECHO session? If your certificate of completion will be sent to you 2 to 3 weeks after the session date. If you have any questions, email bewelltexas@utesca.edu. These surveys are incredibly important as they provide valuable feedback to improve the quality and content of our sessions to better benefit you and bring you the content that interests you. Next slide, please. Next slide, please. Thank you. The Center for Substance Use Training and Telementoring offers technical assistance for various substance use disorders, needs, and topics through our network of subject matter experts. To request technical assistance, please complete an online request form through the link in the chat, and we'll be pleased to help you. Next slide, please. Join us on Tuesday, August 26, 2025, for a Texas SUS session developed directly in response to needs expressed by your learning community and catastrophic floods in Texas. Together, we'll explore strategies for navigating disaster recovery and delivering substance use and other behavioral health services that meet evolving community needs. To register, please visit the link in the chat. Next slide, please. The Texas Substance Use Symposium, Texas SUS, is back March 2nd and 3rd, 2026 in San Antonio, Texas, and we're thrilled to reunite our statewide community once again. We are also excited to introduce a new TX SUS Regional Summit this fall in El Paso. If you're in the area, stay tuned, more details coming soon. For the latest updates, visit txsus.org. Next slide, please. Please join us for our next Public Safety Solutions for SUD ECHO session on Thursday, September 11th at 11 Central Standard. Let's go ahead and move on to our case today. Taylor, if you can please bring up the case form. Dr. Dillon, please walk us through the case.
Yeah, absolutely. I chose this case just to illustrate how, what we do, although probably make a lot of small impacts, the larger impacts come with time and repeated contact with patients, building up rapport, gentle, persistent suggestions on, improving their health. And so I was going to talk about this gentleman that one of the first patients I saw while doing street medicine. He lived with two other gentlemen under the I-10 overpass and was an active opioid use or heroin user, had opioid use disorder, had chronic recurring skin infections, and also had delusional parasitosis. And so, our first encounter with him, was just kind of getting a feel for what's going on with this gentleman, what's his leading issue. And I think one of the first times I saw him actually did that IND of his arm. And then we put him on antibiotics at another time for cellulitis. Every time kind of asked him like, hey, are you interested in getting into substance use treatment? No. And in fact, I think one time he told me, this is a phase of my life. I like using heroin. I don't really want to be housed. And he was actually a fairly educated guy. I think he had a master's degree. I can't remember in what from UT, but it's just where he was at that time. We saw him numerous times over probably a year, maybe up to 2 years. And then we lost contact for a while, and we later were seeing some other patients at a shelter. For those of you in San Antonio, it's Sam Ministries, one of their shelters they had, and came across this gentleman. And I talked to him, and he had decided he had had enough of the way he was living, had enough of heroin use, was ready to get into treatment. Sam Ministries got him into temporary housing as a bridge to permanent housing. He was in treatment for his substance use, was doing really, really well. And, this was almost 2 years later from the first time we contacted him. And so I just wanted to talk about it just to show that's kind of like the best case scenario and like a ideal situation for patients that we see in street medicine. It's a gradual process sometimes. It's easier said than done, especially coming from an ER background, seeing even maybe some of these same patients in the ER, and I'm sure a lot of you interact with them even out on the streets. But it's difficult to want to do what you want to do for them and what you think they need. But it ultimately you got to wait till they want what you want or what they want what you know they need. And when they get to that point, I think that's how you get sustained improvement and helping them, change their lives for the better.
Great. Thank you so much. Um, I would like to open up the floor for our case discussion. Are there any questions or comments from our team or Learning Network for Dr. Dillon?
Hey, this is Brandon. Thanks for that presentation, both the case and the didactic. It was really interesting. In the huddle, we were talking about how housing, being sheltered or not, really has such a complex relationship between substance use, mental health, and housing, and how, at first we say housing first, get people into stable housing, and then they're ready to tackle their OUD. Sometimes people can't be stably housed until their OUD is, or substance use disorder, not necessarily OUD per se, right? But is under control. And I know there's no magic formula, but I guess to start the conversation, can you talk about how you tackle, what your view of that is and how you approach it when you're dealing with individual clients? I know it's a broad question. I'd be happy to make it more specific, but is it always housing first in your experience? Is it mostly housing first? You know what I mean?
I think, yeah, I think I get your question. And I mean, the bottom line is that every person's different, right?
Right.
I think, I think if you wanted to have a blanket statement that could probably apply to more than 50% of people out there, housing first is probably going to work best for them. Even speaking from my addiction medicine practice, I mean, I have some patients who are homeless and are in treatment for abuse disorder. And that has eventually helps them get a job and get a steady income and then be able to afford housing. And sometimes it's the other way around, like Dr. Miramontes pointed out. Like if I'm going to hand out Suboxone on the street, I know even their antibiotics get stolen that I give them. So I know for sure, Suboxone is most likely to get stolen. And so without stable housing, it makes it very challenging as well. And so, I think there's even some literature showing, contingency management works for some people. So giving them some motivation, some reward, if you do this, we'll give you this. Sometimes it works, not for everybody and probably not for the majority. And so the bottom line is that it just depends. And I think that's where meeting people where they're at and figuring out what they're most interested in and improving and what they feel like they need in the moment and keying in on that and then let that lead you to helping them with the other things when they're ready. But I do think housing first is probably the most effective for most people, but not everybody for sure.
Are you aware of good, low barrier housing where folks who are still actively using substances can sort of do that without being kicked out if they're not disruptive? Because I think that's the other variable with housing, right? With housing first is the maybe a sobriety, quote unquote, sobriety or abstinence requirement.
To my knowledge, the one, housing first community we have here, I don't think they require you to be sober. I do think they require you to engage with some sort of, treatment or counseling, but I don't think you have to be sober to get in. As far as I know, I think one of the other organizations here, SAM Ministries, that does temporary to permanent housing, I do think they require you to be in treatment or be sober. And then I know there's some other shelters in town that you can just kind of walk in, walk out. They don't really care what you're up to, but then that leads to kind of an unsafe environment that I hear a lot of horror stories about. And so there's quite a mix here. Although our real, primary housing first community is pretty new and pretty limited at this point. But it's definitely a good development. And then other than that, it's just it's a wide variability. I don't know if Dr. Miramontes knows of some other specifics on that than me, but that's about what I know.
Thank you. I do have one other question, but I want to wait because I monopolized the floor.
Andrea, I saw that you had unmuted. Did you have a question or anything you wanted to share?
You're talking about me?
Yeah.
Yeah, well, I was waiting to see if someone from the audience had a question, but also I was going to mention that there is a new executive order that that is somehow related to homelessness when they are saying that they're going to try to change the rules when it comes to people who are on the street. So I was wondering, wanted to ask Dr. Dillon is if your organization had considered how that is going to impact the services that you're offering to homeless people.
Yeah, we were just reviewing that just recently, and our kind of take on it was that uh, whatever harm reduction we do currently is not funded by anyone, and it seemed to us that that was targeting mostly people who received federal funds to do that sort of thing. And so, and locally here in Bear County, at least as far as I know, we still have the ability to do harm reduction. So our organization still plans on doing it for now. However, I think it's going to be trickier now to continue our path of like trying to get grant funding that doesn't limit us on what we're able to do. And that's one of the reasons we've been very strategic about remaining all volunteer all these years is because it gave us freedom to do things as we see fit and as we want to do them without any red tape. But it's definitely going to make it more challenging for sure.
Lindsay, I saw that you had posted some thoughts in the chat. Would you like to unmute and add anything extra?
Yeah, I see Lindsay's post, and that I guess I'm focusing mostly on the harm reduction aspect, but definitely I think it's definitely gonna create a challenge for our patients and probably even more of a challenge trying to find them because even the locations or encampments we know they're at now probably are going to be getting cleaned up in a more frequent rate with this new federal pressure on local law enforcement.
And Austin has that problem currently. We've had that problem for quite a while now, them coming in and cleaning up the encampments and losing track of people. Corazon Ministries in San Antonio is a really good resource as well. They have peers and a lot of other services.
Yeah, definitely. We work very closely with them. We're out with them at least once a week on the street, and we have a weekly meeting with them to touch base on patients we're all seeing. But yeah, they're doing great things for sure.
I was going to ask if you could say a little more about wound care as a way to make contact with people in need of services. Because I know, like here like up in the Northeast, Philadelphia uses wound care as a way to like engage and retain people. I mean, not like no one's happy about it, right? But it's hard to once the wounds reach a certain point, like it's hard to not get medical attention, and then they deliberately link that point of care with like introduction to MOUD or housing. Do you think that that's built out enough in Texas, or I mean, what do you think the bigger picture is with that?
So I agree with that. I mean, I do think in our experience, anecdotally, addressing their wounds is kind of a way to get your foot in the door and build some rapport and introduce the idea of treatment for substance use. Um, you know, I think among the outreach organizations here, we do that pretty well. Coruscant especially does a lot of that. Um, I think within our health systems, maybe not, it's not as much. But also the challenge is like these patients don't want to be in a health system. They don't want to go to the ER. If they're in the ER, they're really having to be there usually. And so it's already kind of against them for anyone to be able to offer them something in that short time they're there and build a rapport enough so that they're going to want to, listen to their other recommendations. So I think at least locally here, our best bet is what we're doing and like going out to them and addressing their wounds where they're at, and then from there building bridges to get them into the other care they need.
Thank you.
Lindsay, I see that you raised your hand. Feel free to unmute yourself.
So there's, quite a few organizations in San Antonio, but it's very often like deep south, like the Rio Grande Valley and stuff is very much like linked in with San Antonio, right? Because that seems to me like services almost kind of end at San Antonio. Are there any plans to maybe push a little further south and get some services out there?
Not at the moment, frankly. However, I think with grant funding down the line, if some of that is county-wide, then that would push us to kind of spread out across Bear County, which would help us get a little bit outside of San Antonio. But we have to build up our team first, and to be able to tackle that. Because right now we're barely, covering the entire city, which we do, but we're not even meeting that demand yet. So we haven't really even considered going beyond that yet. But are you speaking of like cities, like even further south, like Victoria down the valley and stuff, or are you thinking just south part of San Antonio?
I was thinking like south of San Antonio, further down in the valley and stuff. Just because I run a recovery sport peer specialist training program, and there's trying to get somewhere for them to volunteer to get their hours done is almost impossible down there because there's no services. There's just nothing.
Gotcha. Yeah. Yeah, not at the moment, but what I would hope is that, within the city itself, there can be something that gets started, that's probably the most sustainable way to do it. And especially, locally, somebody who is familiar with the health systems and other organizations there.
Great thoughts. I saw Sandra, you posted something in the chat. Would you be able to unmute yourself and ask your or comment?
I was just wanting to mention that I was over at Town Twin Village last week, and most of the people in line for food did not live on site. I was not there to do any of wound care or anything like that. Mainly just outreach and with, just letting them know about the screenings for the prevention of colorectal cancer. So they were not really happy to see me there, but I did get to talk to some of them.
Yeah, and we're very familiar. We know those people well at Townsville Village, as well as the food line is actually a separate entity. It's Catholic Worker House. Um, if you don't know, like some background on that, like Catholic Worker used to be located downtown in an old neighborhood. That neighborhood started getting gentrified. The new neighbors didn't like it because there was homeless individuals hanging out around the house all the time. And they eventually got pressured to move out. So when Town Village was opening their campus, they um, invited Catholic Worker to have their own building there. So they run the breakfast and lunch every day, and so that's why you see a lot of those individuals getting food that don't actually live there, because Catholic Worker was never a residential facility. And so a lot of those people who go there have been going there for years, and they just go out there now that it's out at Townsend Village. Um, and I believe, a lot of those individuals who actually get into housing at Townsend Village have their food needs met. A lot of times they don't need to go over to Catholic Worker, but that might be why you saw that. But to your other point, yeah, a lot of the people who go get into housing in Townsend Village, it's an adjustment for sure, especially because those are tinier homes. It's hard for them to be inside, but that's why they created a lot of those front porches. All of them have some kind of outdoor area where they can be outside if they want to help them adjust. But it's definitely a challenging thing for them.
Can I ask if there's any like limitations to your services? Will you only see people every so often, or like only so many visits, or?
No, yeah, there's no no limits on how frequent we'll see somebody. We'll see them as often as we need to, and basically until they can get into housing or get plugged into regular care. We'll even continue to see patients for, the first another visit or two, even after they get into some kind of housing, until they're able to, get established care with a normal like kind of primary care clinic.
And what's your policy on like finding substances, somebody, you walk up to somebody and they're using or they like, things like that.
Um, I mean, always a non-judgmental approach. I've definitely walked up on individuals numerous times actively using heroin. Most of the time, if that's happening, they want some privacy anyways, and we'll just kind of step back. But it's an opportunity, I think, to ask them about it, gauge their interest in treatment, see what they're open to.
I was just to clarify, so you wouldn't like call the cops or anything.
No, I don't. I would definitely
Great.
hand a Narcan if they didn't have any of them.
Great thoughts, everybody. Any other questions that we have for Dr. Dillon?
I was just going to comment on the wound care thing just for a second. So, some of these wounds are actually quite horrific, and they actually require grafting in order for them to be healed. The problem is this: they won't graft them because they don't have a stable environment. They don't have a stable environment, so they can't get grafted. So it's really a rough spot. Even in the hospital, they're going to be really resistant to doing aggressive debridement and a graft if they can't see them and follow up and watch the wound and the graft site. So it really puts these folks in a rough spot. So without, when they're ready to go forward with either recovery or housing, then they can potentially get their wound managed definitively. But is this just a struggle between what the goals of therapy and unfortunately their circumstances that they live, and trying to balance those two things are a very difficult equation sometimes. Even getting them treatment can be tough if they're unhoused. Having to go to CHCS every day at 5 a.m, that just doesn't fit most of our patients' time schedule, right? They're up late, sleep in early, and sleep in late, right? So that doesn't work. The ID thing, getting their stuff stolen, there's a sweep. That, anybody who's had to go get a driver's license in the last 10 years, what a pain in the rear it is, right? And think about it. You have your birth certificate and a social security card and maybe a work card, or you have multiple ways to establish your identity. These people have zero, right? If they lose their ID and all their paperwork, if they're a vet, it can be tough if they don't have their discharge papers, right, to get access to care. So this is a really challenging population. And you just got to kind of have contact, build rapport, and then eventually when they're ready for recovery, they're ready to take a risk to do something different than they do. But until then, we're just trying to keep them alive and as comfortable as possible.
Yeah, totally agree. I just put in the chat a book recommendation if anybody's interested in reading a little bit more about just healthcare for homeless, but also getting a good glimpse into what their lives can look like sometimes. Definitely a good tool to build empathy and compassion. And it's written by Dr. Jim McConnell, who pretty much is one of the fathers of street medicine. He's been doing healthcare for the homeless in Boston for 30 plus years.
Great. Thank you so much for that. And thank you so much for that book recommendation, Dillon. Dr. Dillon. Um, any other questions for Dr. Dillon today? If not, I do have one more question, just because I'm not familiar with this world. I understand that there's a lot of intricacies in working with this specific population. What are some strategies that you and your team utilize to build rapport with them and create that bridge of trust, if you will, that you guys are there to help and not cause any issues or disrupt them or anything like that?
Yeah, it's a good question. I mean, first of all, we approach with courtesy. Kind of anytime I feel like we're coming into an encampment or about to, you're usually entering their personal space much sooner than you realize. And so, announcing yourselves, telling them who you are, why you're there, and then usually with that, you'll get an indication on do they want you there or not. And if they do, then we start in a very, relatable way, make small talk even, ask them, how long they've been there or what their needs are. And then if they point out some specific medical issue, we'll dial in on that if they're willing to. A lot of times they may not be ready for us to do a full history and physical and get their vital signs, which is traditionally what you do, with a patient encounter in medicine. But sometimes we work with them, and if they're focused mainly on their wound or their headache or whatever their issue is they're having or dealing with that day, by focusing in on that and showing them that you can help them and that you care enough to help them, then they'll open up and let you, do whatever the things you feel like you should do to help them, whether it's checking their blood pressure or getting their name, getting more personal information from them, and then helping plug them into resources.
Great. Thank you so much for that. And thank you so much for this presentation. Thank you so much for the didactic you gave us today. In the interest of time, let's go ahead and move on to the case summary. Dr. Miramontes, could you please give us a summary of recommendations for today?
So today we talked about an intriguing topic of our folks that are unhoused and the various challenges that they meet every day just to get through the day, whether it be safety and security, food, shelter, basic health care, mental health care, and the potential for them having challenges with substance use disorder. We talked about the unique issues with access to care, and how a lot of times these individuals are actually resistant to doing the traditional come to a clinic, come to an ER, come to a hospital for care, because they've been traumatized so much. And using a trauma-informed care approach when you manage these patients is key. We may not understand their motivations for why they want to be unhoused, but that really doesn't matter. That's what you have to do, is meet them where they're at. I think we talked to Cressler about ways that we can engage these clients, wound care, referrals for food, housing, or other services, and the challenges that we're going to face now and in the future with getting those services to these individuals that they want them. I think the big takeaway is engage in a trauma-informed approach, engage in dialogue, build rapport and trust, and offer treatment therapies that they're willing to accept. That last part can be tough in trying to educate and motivate them to maybe go a different path. I think this is a very unique environment of care, as we talk about, where a lot of us are not comfortable doing that environment of care. So hats off to the team for trying to engage with outreach. In San Antonio, we're blessed with tons of resources for our unhoused population. But again, a lot of these resources aren't utilized because they've been victimized, traumatized, or they're afraid, or their mental health or substance abuse prevents them from engaging. So bringing down those barriers is key, as our friend has talked about today. And the case examples were good about illustrating those facts. So very good presentation of this unique group of patients that have MOUD and other issues, and then potential strategies to engage them there.
Thank you so much, Dr. Miramontes. And thank you all for joining today's Echo session. As a reminder, to earn continuing education credits, please complete a post-session survey using the link in the chat. If you would like to present a case, please email the Be Well Texas team at bewelltexas@utesca.edu. We look forward to seeing you at our next session on Thursday, September the 11th at 11 a.m. Central. Have a great rest of your day.